I won't need the microphone. I'm going to introduce you then, Vanita, and then you can get started. Okay, so thank you everybody for coming to UHN ClinEpi Health Services Research Rounds today. We are delighted to have Vanita Jassal, who's going to talk to us about program development to research, trials and tribulations. I've known Vanita for a long time, and this is probably the first time I've actually heard her speak to a group of people. So I'm looking forward to that. No, that's not true. I saw you at your professor's night at UHC when you were promoted. For those of you who don't know her, she's an academic clinician investigator here at UHN with interest in geriatric nephrology, palliative renal care. She leads a program to optimize functional well-being of seniors establishing dialysis. And that's all we have for you. So welcome to come and speak. And you like questions as we go?
Sure. It's actually funny to be up here because I don't feel I'm really quite qualified at the moment. It's also funny to have Murray in the background because Murray was my master's. You were committee mentor, but more like a supervisor, right? And I used to meet with Murray on Friday mornings with one of the other, with the geriatrician, Geriatric, one of the other clinicians, clinical scientists. And we used to go through my thesis stuff, and I used to call it my Friday kick because these guys would challenge me at yin yang and put me on the straight and narrow. We had a lot of fun. It was fun. It was, I think, one of my best scientifics at the time.
Very highly cited paper.
Sorry?
It was a very highly cited paper.
Yeah, actually, we did really well with the paper. Yeah. And it also got me through my master's degree, which I'm very grateful for. So today I thought I would also again air my dirty laundry, and I say dirty laundry because these are projects which I personally have some emotional difficulty getting off the ground and moving forward. And some of that's in part me, and some of that is in part, I think it really needs some scientific input from yourselves and maybe some questions. My background is very much in the clinical world and the science world, where I was looking at geriatric patients on dialysis, and a lot of my preliminary work was done really to establish some of the geriatric burdens of disease in this population. And on the side, and I say that on the side, I got involved in developing a clinical program where we could rehab these patients, and that's now come to the stage where I really want to publish this and move it forward from what was at that time learning how to develop a clinical program and put into practice a slightly different practice clinical plan. I'm moving it into the research world, and I think that's really where this concept of trials and tribulations came in my mind anyway. It worked before. Please. It did work, didn't it? Anyways, I have objectives which I put onto the list, which really are not very great objectives, but it was to leave you with an understanding of what we've done with the clinical program. And it was really to leave you with a bit of an understanding of some of the challenges that I now have sort of significantly further down my program that I hadn't anticipated whenever I initially started it. And I started it with the hope that sometime in my life I would be old enough that I would actually move to publishing some of this work. My third objective on the list was really an objective that is about me and not necessarily yourselves, was to stimulate some discussion around how we could actually move forward and try and get some of our work and literature marketed. We're not going to get there. We are. We will. I mean, I can do it from the keyboard if you want. I started off where I wanted to actually introduce you to a little bit of background about renal disease and about dialysis, and I think it's important to put dialysis into a context. It's a clinical therapy that's very commonly put out there. I don't know how many of your clinicians, how many of your scientists But it's very commonly offered for people who have end-stage renal disease. I like this cartoon, by the way. Oh, I can tell who the clinician is. So it's very commonly offered. I think when we are prescribing dialysis therapies, we're not always very clear about exactly why. And I think there are 3 settings where dialysis can be appropriately used. The first is whenever you've got a deterioration in renal function that's very significant, where you expect the kidney will recover. And I consider that to be for acute kidney injury. It's transient, it's only a temporary intervention. The second time is whenever we have a chronic disease that has really destroyed these kidneys, where we need to support the body around these kidneys, even though the kidneys are the best thing there. We need to support the body while we prepare for some form of organ transplantation. And I say that in that particular way because I think in this particular instance, even though there's a chronic kidney disease present, the purpose is really to bridge that individual through until they get a transplant, which is a curative or semi-curative intervention. And then the third group are probably the most interesting and the most commonly seen clinical population, and these are the people where chronic kidney disease is present, where we're initiating dialysis, and if we were to be honest with ourselves, even if we're not so honest with the patient, it's unlikely that they're going to be well enough to ever get a transplant or survive to the time that they get a transplant. And really, this is their destination. This is where they are going to be until the time it comes for dying. And it's this population that has always been of interest to me, and I call it a destination therapy.
For those that aren't clinicians, could you give a 1-minute description of just what
dialysis does
for what it looks like for the patient? You know, is it a big commitment? Is it a time commitment?
Can I do that on the next slide? Kind of. Kind of. Dialysis is a treatment either done through the abdomen or through blood, where we actually remove or wash chemicals and fluids out of the body system. So every time you and I go for a pee, we lose some fluid, and that happens to match pretty much what we're drinking. But we also lose some toxins in there, and that matches what we have just eaten. I have some nice falafel, minus the nutrients that we actually need. And it's a very intelligent system that loses only excess water and excess toxins and varies according to whatever we have eaten and drunk. The treatment per se that we offer to patients mimics some part of the human body function in that it probably does 2 out of 5 different jobs or roles that a kidney does. And it is a treatment that is really quite burdensome, and I think that's really where you're coming from. It's a treatment that is a never-ending treatment. If you get today, you'll still have to go and get your next treatment. It's a treatment that is continuous and is associated, we used to call it life-saving. I think life-sustaining is a better way of doing it, and it is burdensome. It's not easy even at the best of times when things are going easy. And another way of looking at it is if you compare it to people who are undergoing cancer chemotherapy, you'll get fairly similar quality of life scores. So dialysis chronically day in, day out for the rest of your life makes you feel probably as much quality of life as you have when you're undergoing chemo. That always blows my mind. So it's not a nice or easy treatment. In an ideal scenario, we would be able to offer patients a treatment that would take them through in this curve almost to the end of their life, feeling reasonably well and doing the things that they can do. In a dialysis patient, what would be 100% normal activity for that period of ill health maintained with dialysis would probably be lower than their normal, but still something which is acceptable to them, appreciating that this is a burdensome intervention. This, however, if I'm fair, I have to say is relatively unusual. It's in maybe the top 30–50% of the population, not all. More commonly, what we see is that a patient will do relatively well. They'll have the odd intercurrent illness or episode where they'll require some other form of usually hospital care or some other treatment. Maybe they'll recover close to where they were before, but over a period of time, these recurrent events will actually result in a deterioration in their overall well-being and their health. And I think what we often see is much more frequent hospitalizations as they approach that end of life. And so this graph perhaps is not very representative. It doesn't show how frequent these hospitalizations can be and how long sometimes they can actually be. And this is what I would consider to be a chronic disease trajectory. Now, I think dialysis is particularly unique because there is also a third trajectory that's a little more difficult to understand. And this is often a trajectory that nephrologists don't always recognize. Is that fair? When the patient is started onto treatment. So they've got chronic kidney disease, we know they're going to start onto dialysis. And in that very short period when they initiate a treatment, for whatever reason, we often see a decline in their overall well-being and the impact it has on their lives. I don't know whether that's because we use a treatment that is so burdensome and they have to adjust, or whether it's because they were so unwell and that's what triggered us to start this treatment. But there's often what I would describe as a significant functional decline. They stop doing things. A young person who was previously just about getting to work but wouldn't go out at night because they weren't feeling so well will stop going to work. And they often do not resume those activities even with the intervention, maybe more so in the older population than the younger. So there is this trajectory of a decline. And this really relates to the clinical program that we started to establish, specifically looking at older people, looking to see if we could introduce some form of rehabilitation or intervention for this. If I look at my older people who initiate dialysis therapies, I can kind of get a sense of how well they're going to do clinically. These are two graphs, which are figures or studies that kind of support that thought. In the first one, the one labeled B, this was a group of patients who initiated dialysis, and in the first 6 months, may or may not have been transferred into sort of supportive care settings. So what you and I would probably consider as being CCAC supportive care areas. In this particular project, they were able to show that if you had what they called non-disease specific problems, difficulty getting up to walk, maybe some mild cognitive impairment, maybe requiring some help with your clothing or with your cleaning in the house area, you actually had a higher mortality. And if you look at this graph very carefully, what you can see is within the first 6 months, if you had a significant number of these impairments, almost 40% of the patients starting dialysis would die. So we're not talking about 10 or 12%, we're talking about 30 to 50% of the population starting dialysis would die in a fairly short period. And it related very closely to what we don't consider as being medical disorders, but sort of social disorders, cognitive impairment, functional impairment, fall. Another paper that supports that concept just very simply asks, could the person walk shortly after they initiated dialysis? Could they walk independently? Were they ambulatory or not? And once again, you see exactly the same statistic. Within the first 6 months or so, you actually have a very rapid decline in survival rate. So then almost half of the people who could not walk at the time that they initiated dialysis would die within the first 6 months. So again, reflecting this trajectory that I showed you before, when you start dialysis, there's a big decline, and can we intervene? Now that first 6 months is critical for lots of reasons. People are more likely to die regardless of anything, and people are more likely to consider stopping dialysis and actually allowing themselves to die in that first 4 months. So again, this is a fairly difficult period to categorize and to understand. Let's switch then to a little bit of background about rehab before I get into some of the trials and tribulations we have with the program. Rehab, we know, in a general population, in an internal medicine or surgical population, can be quite effective. It's effective across a whole lot of disease groups, and I don't need to reference that. We know that. We've actually heard some presentations about it here as well. But we also know from the literature that dialysis patients don't seem to have access to these rehab facilities. In fact, somewhere in the region of about half to a quarter of people who theoretically should be getting rehab or would otherwise get rehab if they weren't on dialysis seem to actually be accepted into programs. And with that in mind, whenever we started our clinical program, we decided to set up a formal relationship between dialysis and geriatric rehab. I said collaboration across 2 disciplines. I should really have said 2 hospitals. So the Toronto Rehab Institute, at that stage a different UHN facility, and ourselves set up a relationship where patients would be accepted into one particular specialised unit to have dialysis and geriatric rehab at the same time in the same unit with the same teams working collaboratively together. The process was quite simple. They got referred, they got initiated onto into clinical rehab program. They had dialysis on site, and I would provide the dialysis care, the others would provide everything else. We would work together with a subtle difference in that we introduced short daily dialysis as opposed to a 3 times a week routine. A minor difference, I think a minor difference in the dialysis, the way we delivered it, which allowed patients to participate a little bit more frequently in their rehab programs. Most of my earlier work was actually around program metrics, just justifying that the program was working, supporting the staff in terms of their learnings, trying to ensure that we had some staff, less staff turnover and some satisfaction, making sure from the patient perspective things were running well. And a lot of times what I was reporting was the number of transfers out and the bounce backs and the types of times of transfer and rehab statistics. And it's only more recently that I've moved towards having a little bit more of a research perspective on it. And it really is a wealth of information out there that we can potentially use. As a research opportunity, I thought it was fair for me to focus on 3 different angles. One is taking the angle from the patient's perspective, what is this for me? 2, taking the angle from a healthcare organizer perspective, what does this do for us as healthcare providers? And 3, as a clinician, what is it that I need to know that I can perhaps get more information on? And hopefully I'll be able to show you some aspects of these 3 different areas. Might leave the 3rd one out if I don't have enough time. What are the research positives? So the research positives of using a clinical program in this particular instance is that I was quite diligent very early on to build a really robust, I think robust clinical database. So data are entered actually at the time that the patient is admitted with regards not only to their clinical data, but the severity of their clinical data using a fairly formalized process. This includes comorbidity, the clinical status, and lots of information around what's going on. And it was designed in a way that we could actually have clinical printouts and information and maintain information, but it was designed with a background that was quite robust and categorical research quality. We also prospectively collected data through the administrative process on the hospitalizations and the FIN score. And the FIN score is a nice-ish government mandated measurement of functional status in patients undergoing rehab. It's mandated, so all clinicians have to be trained in it. It has to be applied at the time of admission, and it has to be applied at the time of discharge, and it's completed by the clinical team at that particular time. And so theoretically, it should be a fairly good, rich research resource or a positive. So here's what we did. The first question we ask is, does rehab actually improve the functional status of dialysis patients? Fairly simple question. Basic outcomes, if I looked at my data, you could see that the patients appear to be relatively appropriate. Now, I put in there some snapshot referral information because I was interested to know, did we accept everybody who was coming? So of the people who were referred, 79% were accepted, but only around 60% actually got admitted. The rest either had an acute intercurrent illness, had to wait too long and went elsewhere, which was really quite disappointing, or died from something else. I think the majority were that they had an intercurrent illness and didn't come as a result. That notwithstanding, we had 989 admissions over a 14-year period, so it's been quite a large program. We have, typical for dialysis, more men than women, and because of the program age recommendations, most of our patients are ranged somewhere between 65 and 85 years of age. We actually do have patients as young as 52 who physiologically have some of the conditions that one would see in older age groups. A lot of our patients were exceptionally unwell. 20% had previously had ICU care with pressures and ventilation. 30% had very complex hospital courses that were often prolonged greater than 30 days. And on average, the mean duration prior to coming to rehab was somewhere around 67 days. This is actually quite expensive if you think about it, quite serious something. Bottom line, after all of the analyses, we were able to show that there was a significant change in admission and discharge FIM scores. And if I look at it, somewhere in the region of 75% of patients had an improvement in their FIM score from baseline to discharge, suggesting that the program actually had some value in improving clinical status for you.
Yes, I just wondered if you could give a little more detail about the rehab. So were you going to talk about that?
No, I wasn't. In terms of
if it's intra or intradialytic exercise and the type and the intensity.
Absolutely, yeah. So the rehab is not intradialytic. The rehab is actually in a program where there are PT-OT foci, and they undergo approximately 1 to 2 hours of rehab every couple of days, formal, with supportive sessions in group settings on the non-one-on-one days. It's very much like an active geriatric rehab program, minimum tolerance 45 minutes per day, and the dialysis then was a short daily dialysis outside of that, done either very early in the morning when there was unlikely to be any rehab, or usually in the evening to allow for maximum intervention. Does that answer your question?
And was it both sort of functional, sort of strength training, aerobic training? What sort of?
Oh, this was geriatric based, so often functional training, looking at mobility transfers and day-to-day ADL, IADL practice. We're not really talking level of function where they would be doing necessarily strength training in the more traditional sense, so it's a much lower level of function. And probably you can see from the FIM scores there.
What is the FIM based on, which variables?
Yeah, sure. So the FIM score is actually a score that is both cognitive and physical. It has 18 different dimensions, of which 5 are actually cognitive. So things like understanding, speech, communication, emotional, and the 5th one is God memory, I think, is the 5th component. The physical function, of which there are 13 involved, simple things like upper dressing, lower dressing, feeding, toilet, clothing adjustment, toilet transfers, bed to chair transfers, mobility. I haven't done all 13, but you've got the sense of it. And this system is designed in a way that it's according to the level of independence, where people who are totally dependent get a score of 1, leaving us a minimum score of 18. And where people who are fully independent, you and I, would get a score of 7. And interestingly enough, there's also a threshold where if you are able to walk with a cane, even though you're totally independent, you would get scored with a 6. So you can have an assisted independence, or you can have full independence with no assistance in these scores. So it's a nice, neat type of score. It does suffer from both floor and ceiling effects quite severely. In this population, perhaps less so than in many other populations, from what we can see here. But there is that sort of messiness of it, if you want to call it that. Is that fair? Any other? And I should have stated right up front that the higher the FIM score, the better the outcomes, which is why the second one looks better than the first. I've got this backwards. I was wondering why I did that backwards. These are the patients in terms of their demographics. And actually what I did here, and for one of the publications that we currently have under review, we identified those incident patients. Those people where we have this very rapid decline in the dialysis trajectory, where things seem to go wrong and one would anticipate you should be able to fix it. 449 admissions. Again, these are patients, some are in the age group of 65 to 85 in the majority of cases. A lot of them are vasculopaths with diabetes, hypertension. And in terms of charts and comorbidity index, this is modified for renal disease, so it's very high. The average in a dialysis population would be around 4, and these are in the range of 6 on average, ranging between 4 and 9. You can see a significant number of patients had quite a significant degree of cognitive impairment, and we had a lot of patients who came to us having been in the acute hospital setting. Only around 6% actually came from home rather than from a transfer. Many of them had had long hospitalizations, as we saw in the other data. There's only a small number actually with volatile fractures. I should have done this the other way around, and I apologize for it. Not only did we see an improvement in the admission to discharge FIMS, but we saw improvements in virtually all of the various different tasks. And you can see the FIM physical tasks listed here on the left-hand side. What you can see is that a lot of the patients at the time of admission had difficulty even with simple things like grooming and dressing, a lot of difficulty with their transfers and with their mobility. And after a period of hospitalization for rehab, they had quite significant improvements. In the group that actually there were incident dialysis, our baseline FIM scores were very similar to the overall population, but our improvements seemed to be much larger, again, in keeping with what the theory was when we developed the program.
That's a question. What are those two categories that they are almost zero over there? They're missing. Is there something there, or is this an empty?
These two? These
yes,
ones here?
Yeah.
Those are just the gaps, because I dropped them into eating, grooming, dressing. This was all to do with poo and pee, or cleanliness. And this was all to do with mobility. So just in terms of clinical-wise, they sort of seem to group together. And they also group together in a way with what we would need to do to provide services. So, you know, I really only need you to get dressed twice in the day. And I really only need you to get in and out of bed once in a day. And if you don't walk around and do the stairs, I can manage without. But these things, in terms of toileting and transferring around, you probably need to do more often. So again, it sort of just seems to group in my mind that way. Those gaps are just illustrations. Thank you. In this population of incident patients, we therefore, unlike what the literature before had sort of suggested to us, we were able to get a lot of our patients home, even with a bit of CCAC support. And this graph is really essentially to say that if a person came from home, they were often able to get home. If they lived in an assisted living space, they were able to get back into that assisted living space. So it was a similar sort of discharge setting. I put it in the green. This yellow gap here, which is actually the bulk of the patients, represents patients who came in where they were independent before. By the time they went home, they needed a bit of support from CCAC, but they were able to still live within their home environment. And for us, that actually would still be considered in amongst the green and the optimal, not doing badly. Those in numbers in the red area are where there was a significant enough deterioration in their functional status that they required some sort of a transfer in terms of the living setting. And that previously has been published as being occurring in more than 70% of the population. And in this population, it is relatively unusual and unlikely. Again, observational results, hard to know what to compare to. We tried to assess it from a patient's perspective as well. In a subset of patients, we were able to do some quality of life scores. I don't want to go through this in too much detail, but just to show you that the average FIM score, as I showed you before, was suggesting an improvement post-rehabilitation. And together with that, the physical component score of the SF-36 and the mental component score of the SF-36 both seem to improve in those people from before to after rehabilitation. Minor improvements in the mental cognitive scores. We wouldn't really expect that we would be able to reverse some of that. The physical scores seem to parallel also some of the other kidney-specific quality of life questionnaires. Although these changes were very mild and minor. The problem with those data is I don't know what to do with them. They're observational. I don't know whether that's significant, not significant, good or bad. And oftentimes whenever we've submitted to manuscripts, they turn around and say, well, so what? What's it compared to? What do you expect? So we try to take a different perspective from this, try and get over this sort of trauma of the question, like, so what? And try and look at whether the rehab outcomes are meaningful from a payer perspective. Does it impact other outcomes compared to people that we would anticipate have no functional impairment? And if you remember, what I had said was I anticipate a lot of these patients would die very quickly and they would actually have a significant functional impairment from observational data. Let's see then if mortality is different or hospitalization is different. Is it lower in this group who have functional impairment? So we set out to look to see whether there was a difference in mortality, hospitalization, healthcare utilization between those individuals getting rehab and those individuals not getting rehab. There's no real good comparative group. So the problem, of course, is if you don't get rehab, it's because you either don't need it or you're not going to be accepted for it. There's a process in there which causes a really distinct bias. You have to be referred, you have to be accepted to the program, and you have to actually turn up in the program. So how do we match for that? How do we balance this out? If I look at it graphically, and this is the whole 100% of people who initiate dialysis, I would anticipate there's a number of people who have sufficient independence that they don't really need rehab. There's a bunch of people who are so dependent that no matter what I did, I'm not going to actually make them better, that never get referred. And then there's a whole lot of people in between who are appropriate for rehab, of whom some will get referred and accepted. A small proportion, we know those numbers, will get referred but not accepted. And then many people will not be referred. And how do we tease this out from a population of all patients initiating dialysis? It's a big question. I don't know that I know the answer. Dirty laundry, so I'm willing to take any further suggestions. Here's what we did do. We decided to use ICES data. I shouldn't call it ICES, ICES data for comparisons to see if we could pull out a population that matched those who underwent rehab. And we decided to choose people who had undergone rehab within 3 months of starting dialysis, looking for survival and looking for hospitalization outcome data. Now, ICES data, as you know, pulls information from 7 different databases. The main ones that we were using were the rehab data set, the NRS, and the ClinEpi data set, which houses within it a core, which is the Canadian Organ Replacement Registry data, which measures everything with regards to renal replacement therapy that is chronic. We chose a time period of 2003 to 2014 because we knew that the data were complete at that stage. And we identified dialysis patients as being 2 dialysis billings during a rehab hospitalization, assuming that you have rehab or dialysis billings at least 3 times a week on an average day, or an average person. I forgot to do this bit. We chose the index event date to be the date of hospitalization for rehab therapy in the population who got rehab. And we randomly allocated an equivalent date in those individuals who were not rehab, who did not undergo rehab. And for each individual, we had a look-back window of about 5 years for diseases, of 1 year for hospitalization. And we had a look-forward window of at least 1 year right through to study endpoint whenever we had data, which was the end of 2015. We used the 2 different databases to identify and overlap patients. So for the rehab data set, we chose anybody who had inpatient rehab over the period 2003 to 14. We identified if they had at least 1 dialysis code within the 10 days from the time of admission or during their length of stay. And we kept that as our pot of people with dialysis and rehab. We then went to the ClinEpi data and identified from ClinEpi and from the Canadian Organ Replacement Registry those individuals who had had a chronic dialysis code build. And we chose initially just one chronic dialysis treatment so that then we could be more inclusive, although 2 would make us into our criteria. With 24,000 patients over the period of interest, of whom we excluded many because they were aged 66 or less, and who had been on dialysis for more than 180 days. We then defined those people left over, around 13,000 of those individuals as being newly started onto dialysis. And from them, we were able to divide them into those that were found in this particular pot and those that weren't. People who had rehab and people who did not have rehab. And the split came out as 920 new starts and rehab individuals. When we looked at our total cohort, you could see that the no rehab individuals were predominant, with only 920 getting rehab. And the rehab patients were on average a tiny touch older, sicker, more likely to have had ICU starts, and more likely to have had multiple hospitalization or GP visits. So they looked as if they were less well to start off with. We assumed that they had a dissimilar prevalence of mobility limitations, functional status limitations, and cognitive status limitations, just because that's why you get into rehab. With that in mind, then we went forward to do some matching, and we did both hard matching and propensity matching. Hard matching was done for age and for gender. We also wanted to exclude patients who would have died in the period from initiating dialysis until getting into rehab, because that obviously is a bit of a limitation. So we matched hard match from the day the first dialysis through until this either artificial date of rehab or real date of rehab. And then we did a propensity match looking at the wellness of the patient. And there's various different parameters introduced into the propensity match, included the vascular access type, whether it was a line or a fistula, a 6-month look back at whether they had had ICU care, whether they'd had a major surgical procedure or a diagnosis of sepsis, and a 5-year look back for comorbidity and illnesses, with special emphasis placed on transplant and liver disease that would not normally be in comorbidity things. With that in mind, we find that our matched cohort was a little more representative of one another. Our numbers dropped to 765 in the rehab group, but matched 3-to-1 with non-rehab patients. And reassuringly, we found that the change in the FIN scores was very similar in the population that we had who underwent rehab. So it sort of matches the clinical data before. Disappointingly, though, if you look at the numbers, it's only 765 across the whole of Ontario, where I find 449 in my unit here. And so clearly we were missing several patients for some reason through this matching and this identification process. Bothersome. When we looked at mortality, however, we found absolutely no difference. Now, I don't know, is there no difference in mortality? Or is that meaning that there is not the difference that we would have found otherwise? I don't know how to interpret these data. Again, I'm really keen for someone to give me some input as to how to market this. I'm finding it difficult. We also found that the rehab group spends marginally more time in hospital, so it doesn't cut back on hospitalizations, despite the fact that I would have anticipated this as a population who would have spent substantially more time in hospital. Again, looking at the proportion of remaining lifetime years spent in hospital, it's around 2%, ranging between 0 and 11. When Helen and I give a prognosis based on the data, we would anticipate in this sort of a population, the hospitalization, the proportion of time spent in hospital to be close to 30%. So I feel that this number is substantially lower than what the literature has published before. But again, hard to say that whenever you're comparing with published literature. And does it impact outcomes to come to my unit as opposed to other units across the province? The answer is no. Unfortunately, we were not able to find that there was a difference there, either because there isn't one or because we actually didn't identify anywhere near as many patients as I would have in the clinical database, it's 163 compared to 449 for the same time period. So a substantial loss through this matching process with Ontario-wide data compared with the clinical database. Again, input really appreciated. Should I stop so then I have 15 minutes left? Oh, this is my strengths and limitations. I've kind of identified some of these already. The third part of the studies that are sort of relating to this relates to the development of a predictive model, but we're still working on that. Should I stop and have discussion, or should I continue?
So you had that nice bar graph showing the kind of people who get into rehab. A few slides back.
This one
the
here?
One you speak, this kind of conceptual.
Oh, the conceptual list.
Yeah. This one.
Yes.
So you're trying to recreate this, applying these rules with the administrative.
Right. So with the administrative data, I'm trying to cream off these people because they wouldn't have the comorbidities and the matching. Cream off these people as much as possible, although I don't know how you could totally cream them off.
But you're identifying people who were on dialysis, at least one.
Yeah,
right?
So I suspect that there are more than one. Whenever we look back, it looked as if they were on dialysis, they were being captured more. The reason we chose one was if you had one treatment that was a chronic dialysis treatment and then died, we needed to actually understand that you were a dialysis patient who happened to die, and that's why we have such a low threshold.
Okay. You said chronic dialysis. That's
correct.
It wouldn't just be.
Not the acute dialysis. And acute dialysis billings are billed slightly differently through OHIP, and that's how we could identify what we could identify. Surprisingly, dialysis billings are apparently not as reliable as you would think, even though it's a fair amount of money.
You've seen that, it's a bit of a contradiction in terms. You said you had to have one chronic billing. Chronic to me seems that.
Right, it's to account for death.
It's to account for death, yeah.
So ordinarily, if we were to look for dialysis patients, we would say you needed to have 2 dialysis billings over a 90-day period. But I know that 90 days is too long for survival for many of these new start patients in this age group. And so to be able to account for these patients and be open to it, let's say they've been transferred to rehab in the first 2 weeks, I needed to match to people who would be equivalently doing it. So I didn't have that criteria in there as a result.
Okay. But in practice though, I'm just thinking out loud, I haven't thought this through the way you have, obviously. Like you might look at someone who's really ill, who's likely to die in the first 90 days and say, you're not a good candidate for rehab. So your mortality was lower in the rehab program, isn't it? And
no, it was the same in this matched program.
No, sorry, in your own data from your program, didn't you have lower?
No, so we would have had the same mortality, and we only followed to the end of their dialysis treatment. There's a whole privacy issue, and I'm not allowed to ask them what's happening to them afterwards through UHN privacy.
I was wondering if you're including, by saying one chronic dialysis treatment and you're in this analysis of the admin data, you're including people in your dark blue box who maybe you would not include in practice. Is that possible?
Of course it's possible. It's less likely because I hard matched the time from your first treatment through until when you got rehab. I hard matched that time. So let's say you started dialysis today and 3 weeks from now you entered into rehab. The equivalent person would have had to have survived the same 3 weeks. If it was 8 weeks, they had to survive the same 8 weeks because I think that is a survivorship bias, and we hard matched that. I was absolutely obsessive about it, and I asked for the ICU matching as well for that very same reason, because I think it was also something that really caused me concern in this batch. Murray, I saw your hand.
So 95% of the people in your program are from hospital discharges, right?
Yes.
So these are all people who have been really super sick, and then they're coming to you for rehab. And I would imagine that the bulk of them are also people who have been on dialysis for a while. These are for the most part not new dialysis starts. These are people.
So in my data set, it's about half and half actually. So a lot of them were the new starts. I mean, I particularly promote that, so that might be part of it. But
I'm just wondering how representative the ISIS cohort was for your data set. I mean, it's obviously you've got a very sick. I mean, we sent a few people to you too, so I know the kind of high degree of comorbidity, low degree of function, and it seems to me that, like, are these the same patients that you looked at in that mix?
They couldn't find, I anticipated that they would find, if they weren't going to find 449, they would find 370 patients that belong specifically to my unit. Actually, we can identify whether it's from my unit or not my unit.
But I just meant in terms of inclusion criteria. Did you exclude?
So, we shouldn't have excluded them, no. No, there's something with the ISIS data set capture for dialysis billings and rehab, or with the, again, the chronic billing process, which I think has led to some errors and some flaws, but I do not know how to overcome them. And we tried investigating that a little bit more with all sorts of tricks that they had used previously for acute kidney injury analysis. This was the renal group that were doing it for me, but we couldn't identify any more patients.
I just, so a lot of frailty related variables, like I just wonder how well you were able to match for that, because
can't match at all.
You can't match at all. So, you've got Charleston as a sort of a proxy for frailty, but you could have done Charleston ADG or a high dimensionality propensity match to try to get at some of that frailty, because I would imagine that the ones that go to dialysis are not the same as the ones that, the ones that go to rehab are not the same as the ones that don't. And a lot of that is related to variables that are not easily gotten at in the ISIS data.
And I think that's where I'm having difficulty. I actually haven't even put this manuscript together because I cannot get my head past it. That this, to me, is an incomplete match. My population should be sicker, even though I've done a propensity match to people who look the same. The fact that you're not referred for rehab tells me that you're not the same. And therefore, I should see that there is a higher mortality in my population than in the other. But to sell a negative finding is, I just find it unbelievably difficult to understand how to do it. And I don't know a way to move forward. That's why I thought I would bring it to the group.
Well, it's one thing to sell something that you believe. The question is whether you believe it. And I personally would go down a little bit further down the road of trying to adjust for comorbidity before you accept the fact that there is no.
How else would you accept for or adjust for comorbidity?
So you've got Charleston score.
No, so we have 5-year look back for hospitalization and hospital diagnoses through ClinEpi.
Okay, but I mean, so you could look at ADG groups. That's the standard.
They did it using, so their comorbidity match was using the Johns Hopkins hospitalization, the JHRI. So
maybe it's the same thing.
Yeah, it's an ADG group-like thing, but it's a Johns Hopkins.
EDC?
Sorry?
EDC, the Extended Diagnostic.
No, it's the JHRI. It's what it's Johns Hopkins, and it's I've forgotten what the RI stands for, but it's a administrative database comorbidity extraction process. It's like an ADG group.
Probably the EDG. That's how it's referred to. I don't know. I'm going to stop talking in a minute. Like, do you know the literature around comorbidity adjustment in dialysis patients? I mean, have people looked at which of the standard comorbidity instruments best get at frailty in dialysis patients?
Best get at frailty, no. I do not know that. I don't think there is anything for best get at frailty. If you look at the frailty, I know the frailty dialysis literature very well, and there's really there's clear data suggesting that frailty is not well captured in any of these administrative data systems or even with the quality of life questionnaires. It's not accurately, it's overrepresented rather than underrepresented, and it's not well captured and adjusted for. In our own Canadian healthcare system, there is nothing around it that I am aware of, or that the ICES renal group were able to come up with, which sort of adjusted for this concept of frailty. I tried to get home care utilization statistics as one of the things, but the problem again that we ran into was that this was probably not representative. That might have been representative of you before dialysis, but not necessarily at the time of referral.
I don't know, like, so people now, I'm going to stop talking now. So do use these high dimensional propensities for approaches, and that's something I would probably have looked into a bit more to see if there's anything in those codes that you could torture into producing something that looks like a more complete
match.
Anyway.
I'll take any other suggestions. I don't know how else to identify these people either, because we're not getting them all. And I, from the clinical perspective, the people that they've captured as undergoing rehab, it's not the sort of rehab that we're performing across the street. It's quite different, and so I have concerns about that too, that we're not capturing this correctly. But I don't know how else to validate what we're doing.
Do you have time? Sorry. Do you have time from last hospitalization?
I did not do time from the previous hospitalization to the hospitalization provoking rehab. I did the number and the days in hospital in the last 6 months. I included that as a hard match. The number of hospitalizations in the prior 6 months and actually the days hospitalized in the past 6 months. We have in there included also the number of GP visits as a capture of what's going on, assuming we have a Canadian healthcare system that's sort of fairly representative. I have that too, but not.
There's some people you couldn't match from the rehab side, right?
Yeah, there were too sick.
They're too sick.
Yeah, the people we preened off were the sicker people rather than the less well people, which also disturbs me.
Have you looked at two things, like geography and proximity to a rehab clinic, and also by doctor? Thinking like, if a doctor has made referrals to rehab, then they are obviously making some decisions about who goes and who doesn't. If a doctor doesn't make any referrals,
right,
maybe they don't
propensity for
know, and so maybe it's less different.
I did do the geography, and we actually did, and I don't have the breakdown with me, where we looked at urban versus rural distance from the nearest dialysis unit, nearest acute care centre, and there were distinct differences, and actually we adjusted for that in our propensity match. I didn't list it here because it was one of those sort of less transparent things. I do not have the doctor. I have a bit of concern because within nephrology anyway, we all practice as groups. We tend to share, so someone might be under my name this week and somebody else's name the next week, and I wonder whether, I might have initiated and they don't, but they carry it on. So I'm not sure how easy that is to do. It's a thought. I can probably go back and ask, but I'm not so sure. We tried to limit the initial analysis report was written because my clinical knowledge is we don't have other inpatient rehab centres for dialysis patients across the province. It's actually Toronto compared with everywhere. And I asked for urban centres to be compare Toronto to Ottawa and see what's going on. It was because we couldn't find the patients in my centre. We couldn't actually identify the same patients that I could identify by name. They couldn't identify by number, and so we expanded it to look at other things. But I don't know if I could do any more than that. We do have postcodes and stuff like that, yeah, of course. You're supposed to give me solutions, actually. This is wearing dirty laundry so I can get solutions. It's not just...
So you showed at the beginning those two cumulative incidence curves. One with patients ambulatory or not,
Right.
and the other one with a whole bunch of non-disease. So you don't have any of those things in here, right? Those things I'm just trying to think of something, like, I guess my own intuition, something's not there in the matching that is used when you're deciding whether a patient is eligible for rehab or not. So you're matching on things like diabetes transplants. Maybe there's some other stuff that you only see when you look at the patient, or you have some non-clinical information to decide whether the patient's a good candidate for rehab. And if you're not matching on that, then even though these things are all the same, there could still be differences between those two groups on something that, you know, is important.
RAI assessments or something, if they're available. I don't know if they're always available, but it might be something that we could see.
The SPIM, if you have that as an outcome, everyone. If you have it, you could use it too.
I don't have SPIM in people who are not going into rehab because it's only mandated in
Right,
rehab
in rehab.
individuals. So all I can say is that the SPIM in the people who are identified looks the same as the SPIM that I can identify
Right.
from the clinical data set. I can't do it the other direction. Otherwise it would be a gift. And I can't randomize them. I did try.
Any cognitive things you can match up? Might be important.
I don't know how to measure the cognitive things. I mean, they're not measured. They're not captured. I don't know how to capture. I mean, these things are just not captured, so I don't know how to match it or how to do it better.
We're doing the MOCAs for the patients, like for our study, which gives you the scores, pre and post. So that's a measure, like what happened when they started initiation.
Right.
I mean, like when you had them, and after the rehab, what was the score
Right.
for them, just like you have the film.
Yeah,
That would give you.
that would give me something. For those patients in rehab, I would have a MOCA on a few of the people, but I would not have them in the people who do not go through a rehab program. And I definitely do not have them at an Ontario data set level.
No, but it's a prospective study.
So the data are collected prospectively, but only in the rehab population and not for a control population. The problem is identifying a control, and not something that I had anticipated at time equals 0. You know, who would my control group be? Because I didn't think of it. And so not something that I've set up in some way where I would get a control group. It's very difficult, you know, you don't get a treatment unless you need a treatment, and how would you control?
And what percentage of people that are referred to rehab choose not to go?
And there is a small percentage, but it's close to only 7 or 8% from the data set, just subgroup that we did. We did a 6-month snapshot. I suspect maybe that actually occurs even before the referral goes in, if you think about the wards, right? Nicholas, I didn't get to your stuff, your very pretty stuff. I think we should probably accept it as being 2 o'clock, right?
You have to come back.
Yeah.
Well, I can't come back because you're not giving me answers. The point would be it's an answer. Thank you. Press noise.